Great. Morning, everyone. Thanks, everyone, for joining us virtually today. I think, as I mentioned, for some of the people that were on already before, everyone should be able to talk during this, just the way the controls are. But we have a presentation first, about 45 minutes or so, and then we're hoping to lead a discussion and answer any questions you have. So you're welcome to use the chat or the Q&A section, or you can unmute yourself and have a conversation with us, quote unquote, face to face. But yeah, thanks all for joining us this morning. My name is Shelby Retmeister. My co-presenter is Mimi Rahman. We're here on behalf of the Center for Reproductive Health Research in the Southeast, or RISE, to discuss a project that we call Pregnancy-Related Care in Georgia's Emergency Departments, also known as Pre-Seed. Let me share my screen and pull up the presentation for you all. There we go. So our presentation specifically, we've called access to care, I guess, is kind of like the main thing, which is a quote from one of the participants from our project. And we're really hoping to highlight how emergency departments act as a safety net for early pregnancy, bleeding, and loss and post-abortion care in Georgia. This project is from a project that we conducted from fall 2018 through summer of 2020, with the interviews occurring in the summer and fall of 2019. So keep in mind, this is all pre-COVID, and the emergency department context is completely different now that COVID has kind of rocked our worlds. But hopefully our presentation, like I said, is going to spark a discussion on how we can improve miscarriage and post-abortion care for pregnant patients in Georgia, especially in rural and underserved areas. So to put some faces to our names, like I said, I am Shelby. I use she, her pronouns, and I was a project director for RISE, specifically for the Pre-Seed project.
And my name is Mimi Rahman. I also use she, her, hers pronouns. I was a research assistant during the time of this project.
All right, so to guide our discussion today, we are going to provide some background on early pregnancy loss, which we define as pregnancy loss, miscarriage, spontaneous and/or induced abortion in the first 16 weeks of gestation. We're also going to go over an overview of healthcare landscape and policies that affect access to care in Georgia. And we're going to discuss then our specific project goals, the methods, and our results to guide that discussion on implications of what we presented and how we can improve miscarriage and post-abortion care in our state, and potentially models that can be applied to other states and other areas of the country. But again, this is very targeted for what we talked about in Georgia, but it might be broader, kind of get other people thinking about it in their own contexts.
So we wanted to begin with some of important time stamps that are relevant to why we initiated the project and why we specifically focused on emergency departments, starting with the Emergency Medical Treatment and Labor Act, otherwise known as EMTALA, in 1986, which mandates that all patients who come to the ED must be examined and stabilized regardless of the ability to pay. Because of this, EDs are a safety net for healthcare access. And with that said, from 1993 to 2003, there were 5.4 million visits to the ED for vaginal bleeding in early pregnancy. Although EDs are a resource, they may not be fully equipped with OBGYN needs or training on gender-inclusive healthcare, but more and more individuals seek care in the ED because of clinician shortages. In 2018, 79 out of 159 counties in Georgia did not have an OBGYN, And in the US, it's estimated that 8,800 OBGYNs will be lost in 2020. And by 2050, it's predicted that 22,000 OBs will be lost. With the expected decrease of clinicians in rural areas, health disparities are getting worse, given that rural areas have a higher concentration of lower median income households and residents are less likely to have health insurance. Additionally, differences in health outcomes are even greater based on race, ethnicity, gender, and sexuality. Next slide, please. So in more detail, the context surrounding EDs, as we've mentioned in the slide before, it shows that EDs are a common source of healthcare for those who experience vaginal bleeding in early pregnancy. However, the availability of clinicians who have the technical expertise to manage complications in early pregnancy is limited to the decrease in labor and delivery units. So approximately 2% of all ED visits are related to vaginal bleeding in early pregnancy. And in Georgia, there were 37 labor and delivery unit closures between 1994 to 2018, with rural Georgia experiencing the most shortages. So this drives patients to seek care in other specialties outside of OBGYN and family planning. Next slide, please.
Okay, so without getting too technical, we do want to provide some background on clinical management of early pregnancy loss, as there are currently 3 accepted treatment options for this care, which includes expectant management, medical treatment, or surgical or procedural evacuation. Expectant management should be limited to first trimester and entails the provider to educate patients on what to expect for a normal amount of bleeding and when and who to call for excessive bleeding. Patients are usually sent home with pain medications and paperwork that outlines these details. Medical management for early pregnancy loss can be considered in patients without infection or hemorrhage, severe anemia, or bleeding disorders who want to shorten the time to complete expulsion but prefer to avoid surgical evacuation. Compared to expectant management, medical management of early pregnancy loss decreases the time to expulsion and it increases the rate of complete expulsion without the need for surgical intervention. Current medical management guidelines mirror that for medical abortion, so management using misoprostol or combination of mifepristone misoprostol when available. Patients who present with hemorrhage, hemodynamic instability, or signs of infection should be treated urgently with surgical uterine evacuation or a DNC. Surgical evacuation might also just be preferable in other situations, including in the presence of medical comorbidities, complications or symptoms, such as severe anemia, bleeding disorders, or cardiovascular disease. But in general, in patients without any medical complications or symptoms that require these urgent surgical evacuations, treatment plans can and should safely accommodate the patient treatment preferences. So ultimately, the guidance highlights importance for patient-centered care models and preferences when considering treatment plans for patients who present for early pregnancy loss. As Mimi was talking about a little bit in our timeline, the availability of OB-specific clinicians to provide this miscarriage management and post-abortion care is increasingly limited due to the recent closures of labor and delivery units across our state. Again, specifically in Georgia, 37 labor and delivery units closed between 1994 and 2018, and rural areas of Georgia in particular are experiencing a shortage of doctors. Therefore, patients who are experiencing early pregnancy bleeding, threatened miscarriage, and post-abortion complaints in these areas would need to seek care from specialties outside of OBGYN. These maps are from the Georgia OBGYN Society and the Atlanta Journal-Constitution. And they show that rural areas of Georgia are especially impacted the most by lack of access to OB care, and that critical access and general rural hospitals in these areas would then be the safety net for patients seeking care for early pregnancy, bleeding, and loss, especially for the most vulnerable of patients who are in need of emergent care and or are underinsured. Again, this is why we decided to focus on the emergency department for healthcare access for this project.
And to bring it all together, EDs really became a gatekeeper to healthcare, especially as it relates to obstetric care. And we will get into more of the specifics in the results section of our presentation, but in their discharge and follow-up planning, ED providers must refer their patients to other resources in the area. For context, though, there are significant health outcomes for patients when considering the variations in access to healthcare. For example, the highest rates of vaginal bleeding in early pregnancy were among 20 to 29-year-olds and are most likely to be experienced by Black, Hispanic, and or uninsured patients. Moreover, in Georgia, there were 79 reported maternal deaths in 2013 that were pregnancy-related and associated. Black Americans accounted for 47% of total maternal deaths, while white Americans accounted for 43%. Black Americans experienced more pregnancy-related deaths, which means it was directly because of pregnancy complications, while white Americans experienced more pregnancy-associated deaths, which means death occurred within 1 year of pregnancy, but not because of the pregnancy. For example, a car accident. With the ED providers we talked to, they did not identify health insurance as a factor when they decided their referral planning, which is what happens outside of the ED. We know that patients who are navigating the healthcare system need to consider their own insurance status for continuity of care. So a way to increase continuity of care and better health outcomes is the Georgia's Pregnancy Medicaid program, otherwise known as Right from the Start, which provides access to healthcare services during pregnancy and 60 days postpartum for those whose income levels are 138% of the federal poverty guideline. Going into more of what reproductive healthcare looks like in Georgia, Planning for Healthy Babies is a family planning program for those who are 18 to 44 years of age, do not have health insurance, are 200% of the federal poverty guideline, not currently pregnant, but are able to conceive, and not eligible for Medicaid. Many of you may be familiar with Title X, which funds the federal family planning program, and currently in the state of Georgia, the Family Health Centers of Georgia is the sole Title X grantee, which supports 130 Title X funded health centers across the state, which includes federally qualified health centers and hospitals. The Title X network served over 66,000 women and over 19,000 men for a total of over 86,000 residents in Georgia in 2015. Nationally, out of 4 million patients who use Title X, more than half are women of color and about 1 in 5 are Black women. The Department of Public Health is also widely used, especially because they may have reduced pricing for services and case management to apply to some of these programs. In rural areas, Department of Public Health clinics are some of the most widely used healthcare establishments. Next slide. From these two maps, the one on the left shows independent abortion providers, which are located in Columbus, Metro Atlanta, Augusta, and Savannah, Georgia. The map on the right shows Planned Parenthood providers, which are located in Metro Atlanta and Savannah. So for example, if you're located in southern coastal plains of Georgia, you're looking at about an hour to an hour and a half drive or more for abortion services if you have access to a personal vehicle. Next slide. With regards to crisis pregnancy centers, also known as pregnancy resource centers, there are 90 centers across the state. And these are typically religiously affiliated organizations that provide varied resources for pregnancy care. In rural areas, they're filling a gap for pregnancy care. For example, in Macon, Georgia, you can't go to a clinic that provides abortions or to a Planned Parenthood for reproductive health care, but you would have a choice of 6 CPCs in the area. This is especially troubling given CPCs do not have the same regulations for quality of care, comprehensiveness of services, and inclusive reproductive health training. Next slide.
Okay. So based on all this background, we took this knowledge and kind of guided our project. So we're going to go into the goals, and we've broken it up into two sections, the overall project and then a sub-project that Mimi led using the project data for her master's thesis. So the two overarching goals are to describe institutional level barriers and facilitators for providing early pregnancy, bleeding, and post-abortion care in emergency departments across Georgia. And then the second is to explore the perceptions and experiences of providing this care for emergency department clinical staff members and how these experiences may have changed in recent years, specifically due to the closure of labor and delivery units and specifically due to policy changes.
And the second part of the project hopes to fill in the knowledge gap of patient-centered approaches to care, or the lack thereof, and its influence on discharge planning and follow-up. The goal of the sub-project is to understand how patients' characteristics inform post-ED instructions. There's little existing research which prevents our understanding of how ED providers and staff attitudes, practices, and their perceptions influence holistic patient experiences.
Okay, so for this project, we conducted 32 interviews with emergency department clinical staff from 10 hospitals across Georgia, specifically focused outside of the metro Atlanta area and in the more rural areas of the state, as roughly displayed in the map on the right. 6 of the hospitals had OB services and 4 did not. The interviews, like I said at the very beginning of our presentation, were conducted in the summer and fall of 2019. So again, keep in mind, this is all, the answers and the context they provide is all pre-COVID, but we certainly should talk about that in the discussion when we're considering the implications of our project. So the interviews focused on their experiences providing care for early pregnancy, bleeding, and post-abortion, and changes in the provision of this care over time. We really wanted to understand what they are currently doing for the provision of this care, whether it is management within their department, consulting with OB, or transferring to another hospital that has an OB, or whether they are stabilizing the patient and sending them home for expectant management and follow-up. So these are 2 tables to represent the participants and hospitals that we included in our project. We interviewed 2 to 4 clinical staff members from each hospital in various roles, which includes registered nurses, nurse practitioners, physicians assistants, and physicians. We had a pretty even split between those roles, and then a few other personnel that we interviewed. Again, we had a diverse range of hospitals across Georgia outside of Metro Atlanta with varied access to OB services, as you can see on the left. Okay, so as I said, for the project goals, we've also broken up the results into 2 sections as well. So I'm going to start with the overarching results for the broader context of what was discussed in our interviews. And then Mimi will follow up with specifically her aspect of the project and for her thesis. Overall, we learned that patients are seeking care for early pregnancy loss management in emergency departments across Georgia, whether or not there is an OB unit in the hospital. So this quote is from a provider in a hospital with OB services. They say that we typically get 4 to 5 pregnancy complaints a day, I would say. I mean, on average kind of thing, that's not every day, but for the most part, it feels that way. So related to bleeding, probably about half of that, maybe 1 to 2 patients every other day. I would say we probably see that are in early stages, and it's ranging from just like spotting to heavy bleeding. And then hospitals without OB, especially those who had recently closed a labor and delivery unit, said they noticed a lower volume of these patients since the closure, but that it's not completely gone. The majority of the hospitals said that seeing patients for post-abortion care is rare. However, when it comes to this care, the interviewees indicated they're more focused on emotional and psychological issues, as well as danger of infection for the patients, more so than they are for early pregnancy bleeding or miscarriage patients. In regards to options counseling, when patients find out that they're pregnant in the ED and indicate they may not want to keep the pregnancy, many interviewees mention that their hospital or emergency department doesn't provide elective abortions, and there's no resources for this care in their community. So they use that as a reason why they don't talk about abortion with their patients as an option, or why their staff is not knowledgeable about abortion or resources for the patients seeking an abortion or post-abortion care. So for the most part, all of the care beyond stabilization for these patients is deferred to their OB. I also want to briefly note that we did ask emergency department providers about experiences with patients who may come in to an ED asking for a reversal for medication abortion, as the counseling for reversal of medication abortion has been a trend in legislation recently across the United States. So we wanted to know if this was truly happening with patients and within the healthcare system, at least in Georgia. And none of the providers had ever heard a case like this. And then we asked providers about their experiences providing care for patients who may have indicated they self-managed an abortion. We wanted to ask about this specifically because we suspect, especially as abortion access continues to be restricted, that patients will consider self-management for abortion and may need to seek care in EDs after to address bleeding or to ensure that the pregnancy has been terminated, or for whatever reason they may need to go to a hospital. Providers in hospitals with and without OB indicated that this does happen, but it's not often. And more often what happens is that the provider suspects that this is the case rather than the patient admitting to self-management, as portrayed in this quote. Obviously, there are many reasons why patients wouldn't disclose this information, and it's not hard to imagine that the patient-provider relationship, especially for vulnerable populations who the healthcare system has failed many times, and especially in rural conservative areas of Georgia, a patient that's going to an ED isn't going to their trusted medical provider, even if they had one. So it's mostly a single interactions. So patients wouldn't necessarily feel comfortable sharing that information. Anecdotally, I've seen movements where advocacy groups and other organizations have advised followers to tell healthcare providers that they are miscarrying rather than self-managing an abortion if they do need to seek follow-up care. So that's the context we went in with for this project and why we didn't specifically focus just on post-abortion care, and why we wanted to talk with them about miscarriage care, because we would assume that a lot of the patients would be saying miscarriage rather than self-managing an abortion. So the following protocol that we do talk about can apply to those cases, and it would be the broader term for all of the care. And ultimately, through these interviews, the important fact that we did learn is that the quality and type of care provided to these patients doesn't change based on miscarriage or post-abortion care, whether it was clinic-based abortion care or self-managed abortion care. Okay, so we know that patients are going to EDs for early pregnancy loss care. From a provider standpoint, the context for why patients are seeking this care in emergency departments is more complex. Providers talked about patients' concerns and characteristics, such as their knowledge of pregnancy and what patients consider to be normal bleeding versus emergent bleeding. They also talk about a patient's access to reliable transportation and insurance, which means that patients may seek care at the closest hospital rather than the hospital with OB services. Providers also discussed the broader community characteristics, which mirrored the background that we provided for the presentation. Communities without OB services mean that some patients would need to drive at least 45 minutes, if not much longer, depending on the area of our state, to an OB clinic or hospital with labor and delivery services. So while this could be adjusted for normal prenatal appointments, it's especially cumbersome in times of emergency care. And the communities with access to OB are still limited by the guidance and availability of an obstetrician. Patients who call and talk to an OB about their concerns may still be instructed to go to an emergency department. But even this excludes patients who need care like outside of office hours, as most OB clinics function on a more 9-to-5 weekday schedule. So if a patient needs care outside of these times, they go where it's open and convenient, mostly the emergency department, which leads to the characteristics of the emergency department. Emergency departments are open 24/7. They accept all patients regardless of insurance type and must triage and provide treatment to all patients who present for care, no matter the specialty of care needed. And in this quote, one provider even said, I call it the, and this is just my little thing, but it's the Walmart, McDonald's mentality. Walk in, get whatever you want, and calling to schedule an appointment for a lot of people in the demographics of this county is just beyond them. I don't know why that is. They just choose to come to the ER because it's easier, it's convenient. Okay, so we know that patients go to the ED for this care. Then we wanted to know what happens when they arrive. And before we discussed actual treatment, we learned that there are some hospital policies and procedures that guided the provision of the care as they arrive and are triaged. So ED providers in hospitals with OB services discuss that anyone seeking care over 20 weeks gestation typically goes to labor and delivery unit, and those below that mark, no matter the complaint, stay in the ED unless otherwise consulted later. As you can see by the quote, which is just one example from a provider in a hospital with OB services. And then hospitals without OB services don't have this hard set of a rule for their transfer patients, but they did discuss more urgency at or after 20 weeks gestation. And then some providers, regardless of hospital type, discuss the triage process and have been able to, whether formally or informally, change the process and policies for triaging bleeding during pregnancy to a higher urgency level, so that these patients are taken back for care as soon as possible and placed in a more private room if available. Okay, so in regards to the ED's protocols for treatment of early pregnancy loss and post-abortion care, the overwhelming majority of providers discussed expectant management. Some providers would discuss medical management, but often we're talking about pain medications, and none of them specifically discuss providing mifemeso as a management option for pregnancy loss. Overwhelmingly from hospitals with and without OB, there was the sense of there's nothing we can do. When our team examined that sentiment a little bit during analysis and our team discussions, we kind of came to the understanding that the framework is there's nothing we can do to save the pregnancy. rather than, there's nothing we can do to help the pregnant patient's experience of miscarriage outside of emotional support. But as we discussed before, ACOG does approve 3 management options for low-risk situations. And for those situations, the ideal management option should be based on patient preference.
So once patients leave the ED, what happens next? And it's from what we found, it was determined whether they were in stable condition, what resources they had, and who was available in the area. So overall, once the patients leave the ED, this can go in one or two ways, through a direct referral or an indirect referral. And we contextualize this with direct referrals are when providers make the appointment post-ED, or there's a hospital-to-hospital transfer that has been initiated. An open referral is when patients navigate the healthcare system and make an appointment with an OB of their choice. So it's more indirect without provider assistance. Next slide. So with the direct referral, there's usually an existing relationship with the referred provider. A direct referral includes transferring the patient to an alternative hospital if the hospital that the patient originally went to did not have an OB on call, or that the original hospital did not have the medical equipment to manage the patient's condition fully. So the hospital will stabilize the patient enough for transport, and patients will approve the hospital transport. The providers will then notify the receiving hospital of the patient's condition, their stability level, any findings that the hospital had from an ultrasound, if the transferring hospital had an ultrasound available at the time. And then they will ask the patient how they would like to get there, whether it be an ambulance or their personal vehicle. Patients may reject ambulatory services due to cost, so transfer times vary based on EMS availability, which can range anywhere from 45 minutes to 2 hours. And once the patients are discharged from the ED, they will receive follow-up instructions, but depending on OB capacity in the area, this post-appointment can be challenging to book. So some, and very infrequently, providers will make the appointments for their patients. Providers share that they make a post-ED appointment for their patient based on the patient's condition leaving the ED, which may call for closer follow-up, and if this was the patient's first pregnancy. According to the providers, the EMTALA mandate requires clinicians to see patients at least once post-ED, even if the patient cannot pay for follow-up visits. And some providers will advocate for this regulation for their patients. For example, one of our providers shared, "We can't let her fall through the cracks. You just have to call the provider or the doctor and make it happen. If the patients call themselves, it won't happen," meaning an appointment may not be made. With that in mind, this quote reinforces that continuity of care can be difficult without provider support. Next slide. For indirect referrals, patients make their appointments post-ED. So some providers will share a list of OBGYNs for the patient to follow up with, but booking an appointment and getting to the appointment is a whole different story. As I've mentioned, there are challenges to getting into an OB office because of pregnancy Medicaid activation delays, and appointments can be booked months out because of limited OBs in the area. Indirect referrals are far more common among the sample than direct referrals. And with that said, there is a need for better follow-up, closer attention to detail for fulfilling follow-up instructions. For example, hospital staff may call patients back to check on how they are and if they found an appointment, but that's dependent on the provider and or hospital's ability. In the results, it seemed like outside of medical discharge instructions, which include coming back if conditions get worse and coming back for lab results, there's not a standard protocol with regards to following up due to limited resources in the area. And that's a need on the provider or hospital side of things. In contrast to direct referrals and provider-to-provider engagement, with open referrals, the burden for continuity of care is on the patient. Next slide. So how patients navigate the rural Georgia healthcare landscape is dependent on multiple characteristics, not exclusive to the ones shown here. Some examples of patient characteristics include whether a patient has insurance and what kind of insurance, public versus private, and their income level. The majority of this population was eligible for pregnancy Medicaid based on their income according to the providers. Transportation and distance to the nearest medical provider was also commonly brought up as an issue for patients. Patients' transportation ability ranged from having no vehicle to having an unreliable vehicle to drive long distances. and or a fear driving because of their vaginal bleeding and early pregnancy condition. Patients' familiarity with navigating the healthcare system include understanding what they want out of their interaction, what their next steps are, and understanding how to access their resources. ED providers often mention patients don't know when to use the ED and they don't understand what a pregnancy entails. The discharge instructions may require additional education to fill in these knowledge gaps for patients. With the added element of first-time pregnancies, this may result in some anxiety and nervousness in the patients, which our providers also described. Next. When referring to characteristics outside of the patient, but also still influencing the way patients navigate the healthcare landscape, ED providers mentioned available OBGYNs in their area. As we mentioned and illustrated, OBGYNs are limited, and OBGYNs that will provide pregnancy termination services are even more limited, which you may recall from the maps early in our presentation. However, the network of available individuals and organizations who see those with a pregnancy include other hospitals, family medicine practitioners, and crisis pregnancy centers. Referral networks paint the landscape of where patients may go, and based on our interviews, this was determined by hospital affiliation, the location of OBs in the area, and the usage of health departments. Additionally, provider-to-patient relationships are built over time and usually with primary care providers. However, in this context, patients may not have a primary care provider, so they'll go to the ED multiple times and establish a relationship with their ED. For context, these EDs range from very small, less than 25-bed critical access hospitals, to fairly medium-sized hospitals with 299 beds. So these smaller EDs knew how to cater to their patients in a much more intimate way because they were local and small, but often less equipped for pregnancy needs. Some providers shared that they see their colleagues frustrated and agitated by patients who come in for pregnancy because they don't have an OB in their hospital and it delays the patient's care, which may result in complications. This frustration may impact the provider-to-patient relationship, especially if it may be one of the first interactions for the patient early in their pregnancy, and possibly their first healthcare visit ever. One provider mentioned that although their hospital may not have an OB, they understand patients come to their hospital because they need transportation to get to the right place, and they called on for more providers to understand the circumstances that lead patients to the ED. These distances to another hospital may take more than 1 to 1.5 hours to get to, and if the patient does not have their own vehicle, the ED is their only option. And finally, case managers, usually from the local health department, help patients apply for pregnancy Medicaid. As I've touched upon, pregnancy Medicaid, or right from the start in Georgia, can take some time to activate. So if we consider all of these elements, it's fair of me to say navigating a pregnancy in rural Georgia and rural areas in general is pretty difficult, and we believe one of the participants said it best, which is why we included it in the title of our presentation. Access to care, I guess, is kind of like the main thing. Next slide.
Okay, so that was a lot of information on the current practices and procedures and for miscarriage and post-abortion care in EDs that we learned in our project. And ultimately, we learned that the bulk of the healthcare navigation burden is put onto patients. So in reality, for any solution or intervention that we're going to discuss to improve access to care in Georgia is not going to be one-sided and will certainly need to be multidisciplinary. Early pregnancy loss and post-abortion care is not specifically an ED issue that they need to fix on top of the realities and the plethora of issues that ED is already tasked to fix. Interventions would need to address the many layers of social and cultural context for why patients are seeking care in the EDs to begin with. From anything to individual knowledge of pregnancy and what is normal versus emergent bleeding, things like access to insurance and OB services, availability of abortion clinics versus CPCs in rural areas, etc. So strategies to address inequities and issues will certainly need to be creative, especially if we want to work within any of the current structures to address the issues now. So for example, for those of you in yesterday's session on inequities in infertility and maternal health, Brianna talked about how the Georgia legislators haven't expanded Medicaid, but there's been a lot of work from advocacy groups, and finally we've been able to extend pregnancy Medicaid from 60 days postpartum to 6 months postpartum. So we're really going to need those creative solutions to work within the current structures if we want to. And even to thinking outside of the box of if we can't increase access to abortion services in Georgia and rural areas, and CPCs continue to be this filling this gap in these areas, how do we ensure that the CPCs are regulated and are providing medically accurate information and services? And then from a standpoint of integrating patient-centered care models into current hospital and clinic-based service systems for management of miscarriage, that will certainly need to bring in OB, emergency medicine, and policy together to support the systems and improve care for patients based on their needs. And we'll also need to consider other more radical models of care based on the community and their patient needs. But meanwhile, the healthcare and policy landscape of Georgia is ever changing. So while we've seen the pattern of labor and delivery unit closures across the state over the past few years, and that ultimately guided our project and our thinking, we certainly didn't anticipate COVID and the impacts that it has had on all facets of healthcare. Anecdotally, we heard that EDs aren't seeing as many acute or pregnant patients during COVID, potentially because these patients are avoiding high-risk exposure areas, which is completely understandable and totally fair. But then what does that mean for patients who are miscarrying that would have gone to an ED? Are they managing at home? Are they getting appointments with their OB? And what does it mean for a hospital system that needs the revenue? And then in context of policy, policies related to maternal and child health that impact pregnant patients are on the docket practically every year in our state. So as I talked about, the expansion of pregnancy Medicaid to cover up to 6 months postpartum, and then the passage and current legal disputes over HB 481, Georgia's 6-week ban on abortion. This is also just talking about the context at our state level. We're all certainly aware that upcoming Supreme Court cases can have lasting impacts on abortion and reproductive health care across the nation. And as we mentioned at the very beginning of our presentation, it's expected that the OB shortage in Georgia and in the US as a whole will continue, and access is going to be increasingly limited in the state and in the nation, I'm sure. So the implications for this project will need to consider the ever-changing healthcare and policy landscape. Briefly, before I open up for questions and a discussion, which we certainly want to have, I do want to thank some of our other team members, and so Doctors Carrie White and Megan Henn, Lisa Haddad and Eva Lathrop, and the other research staff, which are Victoria Donnelly, Alexander McBrayer, and Sophia Filippa. We wanted to thank support from the Rise Center and an anonymous donor for the funding of this project. And then finally, and certainly not least, we really, really need to thank every administrator, nurse, doctor, physician assistant, director, anyone that worked with us to schedule and talk with us last summer. We certainly could not have done it without their time, patience, and flexibility. They're extremely busy, and we really are grateful for their help. And then I will leave this up for a second. If anyone has questions or thoughts after the presentation, please feel free to reach out to us. We are more than happy to talk. And as our project name precede suggests we really wanted this project to be the start of a conversation. We took information from the emergency department clinical staff perspective on how to move healthcare forward in the state and better serve patients, but really we want to hear from you all. If you have questions for us, or if you have other really creative strategies that we should be considering and how to move healthcare forward in our state. So thank you all for talking with us today. Like I said at the very beginning, please use the Q&A and chat functions, or you should be able to unmute yourself potentially. And if you want to just voice your questions, concerns, or discussion out loud, we're happy to do it that way as well.
Hi, this is Lauren Polk from If When How. I had a quick question about just the demographics of the clinicians that you interviewed. Did you all record that? I noticed that some of the responses just sounded really dismissive of sort of the folks that were coming to get care, which is obviously concerning. And I'm just wondering if the demographics of the clinician matched the demographics of the folks who were coming in to get care or not.
We did not record it, other than we recorded their role, how long they've been in emergency care, how long they've been in healthcare in general. I was in all of the interviews, and Mimi was in half of them. I can say anecdotally, no, they do not match the patients necessarily that they're providing care to, but we're trying to be unbiased as possible in terms of like recording demographics of who we talk to. But I think it's really interesting you pointed out the tone of their comments, because from our research mind, it's very hard to like code for tone, but there are certainly times that we were reading through and we're like, yeah, that's coming across not as pleasantly as we would hope from unbiased providers. There is a question if there's a written report on the research. There is not yet. It is to be coming. So stay tuned. We're very excited by this. So.
And to add to Lauren's question, there were some registered nurses that were from the community, so they had less of a they lived in the community, so they were more familiar with what the patients came in with. And the quote that I brought up about being more aware of what patients come into the ED with transportation, with single motherhood, or the conditions that the circumstances that patients came in with, those that lived in the community were more empathetic, more understanding, and they were the ones that seemed to be more willing to go the extra mile in making an appointment or following up with their patients. And there were providers that wanted to follow up with their patients and seeing if they made an appointment, since ED patients are notoriously not able to continue follow-up care for various reasons. But I didn't get to include the quote for this session, but in a previous presentation we've had, there was a comment about the female providers were a little bit more in tune with what patients were needing. I don't know how much weight I can give to our smaller sample size, but those are some of the perspectives we received on how well the providers in their area, in their hospital, were able to serve the patients that came in. But the talk about tone was definitely there, and it'd be interesting to see like how that kind of is patterned by whether a provider lives close to the area, whether they don't live in the area, and if they come in with judgment or something like that.
There's a question about that many RJ orgs work in Atlanta metro area with extension work in rural areas, but are we familiar with locally based community orgs and networks that work in rural areas that undertake RJ work or midwifery doula services that can be supported? That is, as Mimi just said, we had another presentation on this same work to Healthy Mothers, Healthy Babies, a more broadly maternal child health organization for Georgia. So we're doing these presentations to organizations with specific like stakeholdership in Georgia, and especially in rural areas, so we can get this work out to, again, start that conversation and work with midwifery and doula services. I think that's a great suggestion for organizations. In the last presentation, someone asked if it's any model of care of integrating doula services into emergency departments. I think especially integrating all options doulas in emergency services would be vastly radical change and such a cool idea of how to incorporate like patient advocates for this work. We have a community liaison for RISE in general. She knows the organizations better, so she might actually know of a very specific RJ org outside of Atlanta in the rural areas, but I don't personally. I hope I answered that question of this is why we're getting this work out in these various facets. We really wanted to ask you all about and kind of brainstorm with you of more creative solutions on how to address these inequities and access issues, especially in rural areas. So if you all have your own thoughts, or if you all work at organizations that have come up with your own creative solutions for increasing access and address these inequities, we would love to hear from you all as well.
Hi, my name is Mallory Schwartz, and I'm with NARAL Pro-Choice Missouri. And thank you so much for this presentation. I feel like Georgia and Missouri are so similar in so many of these aspects. We've had lots of rural hospital closures. We have one abortion clinic left in the state. We have an 8-week ban that criminalizes abortion. And so what you were saying about folks not disclosing self-managed abortion definitely resonates and makes sense. I'm curious, I understand it was a small study and we're a different state, but I'm curious how applicable you think the results would be in different places, because we don't have the resources to conduct a similar study, but it seems like there are so many similarities that it really is making me think about what the ED care is looking like for both post-abortion and early pregnancy loss. We similarly don't have Medicaid expansion, although just passed it by ballot measure this summer. And so really interested in how applicable you think the issues and questions and solutions are across different places.
My research brain of like qualitative is like, applicability isn't the point. However, I understand what you're saying. In terms, I think especially with very similarities that you pointed out, I would hope that again, we're hoping to have a formal report that can be used by emergency medicine and OB providers and these policymakers to come together to address these very real issues that are not, again, happening just in Georgia. So we would hope that this work can fuel those conversations in other very similar areas as well. Whether you can directly say this is exactly what ED providers are doing in our state as well, I don't think you could say that, but you could say, hey, this is an issue in other very similar situations. How do we at our state kind of be a bit more proactive than maybe we were in ours, and instead of looking back at what have they been doing, what can we do moving forward?
To add on, when I was doing some of the literature reviews and background context to why rural hospitals are closing, and our focus wasn't to explore why they were closing. We were trying to figure out how their closings impacting the management of miscarriage management and post-abortion care. But the rural context is pretty generalizable from what I was reading. And depending on the state's rural dynamic of sorts, transportation has always been a problem. Closures of hospitals have always been a problem because of Medicaid reimbursement. So the policies are really driving these closures in these rural areas, and rural health. I can't remember the word for it, but physician assistants and medical providers get incentives to work in rural areas, and then after a certain amount of years, they're able to leave after their loans are repaid or some type of deal like that. So those allow providers to kind of leave the area, new providers come in. So different practices like that are reasons why rural areas are so scarce with healthcare resources. So not only OBGYN resources are scarce, but healthcare as a whole in rural areas are just not there, which is pretty generalizable to the nation. Now with Georgia and Missouri in particular, Medicaid expansion is a big contributor to why there's such a discontinuity of care, and Georgia has not done that. So if our pregnant patients have Medicaid for the duration of the pregnancy and then 6 months post, what happens after that? We don't know. So things like that are definitely things to consider in state to state comparisons between why there are differences in outcomes with pregnant patients versus states that do have more supportive infrastructures to have continuity of care. And if you think about things from a higher level perspective, like policy, I think there are more generalized abilities that we can draw from and where things can be improved. But also the South, the different contexts versus conservative states versus Midwestern attitudes and policymakers. So those things will also be included with how healthcare can change in these areas.
So there was the question of, did any clinicians express knowledge of the existence of the MNA hotline, the miscarriage and abortion hotline? No, just no. Their resources they would provide to patients were either generic follow-up with your OB, or follow-up with X specific OB, or here's a resource, or here's the address for the Department of Public Health office, or a couple mentioned that they would provide additional resources for pregnancy-related care centers in their areas, which after we looked into were CPCs, but they mentioned there's nothing else in their area. There's nowhere else for pregnant patients to go. So their knowledge of the resources just related to pregnancy care in general was very limited. even not a single person mentioned this hotline that you have supported, so, or that you've linked. So
and our providers, when we ask them about different abortion-related policies, they weren't familiar. Most of them were not familiar with the policies related to it. And if we maybe in a different exploration, our clinicians had limited awareness of the resources in their area, but maybe case managers or social workers, case management would have a better comprehensive view of what they can offer their patients. So we may have not asked the right people for these resources, but incorporating a case management team for these patients would probably do more good for connecting them to care and continuity and ensuring continuity post ED visits.
Kay has a wonderful question of, did any community stakeholders have a role in designing the research? If not, do you have plans for future research and follow-up that involves community stakeholders, such as the nurses who lived in these communities? I love that question. In terms of the framing and how this project came to be, yes, we as RISE have our own community advisory stakeholder board, and we've continuously discussed priorities of the communities that we work with and want to continue with relationships and provide our results of our research to. So we wanted to know what was important to them. At the time for this specific project, in the way we involved community stakeholders is very different depending on the timing of it. Obviously, we needed the buy-in of every hospital, mostly working with emergency department administrators and directors and getting their buy-in and them addressing who in the hospital would be best for us to work with. And then for future research and follow-up, there's a lot of other work going on at our research institute that others have been talking about, and I think there's actually a few panels about that. Unfortunately, I think all of us were talking at the exact same time today, so I know they were talking about how to do community research and the various levels that kind of entails. For this specific project, we're taking this information now and feeding it back into the community in these various ways. Like I said, we'll have a formal report. We are working with the Georgia OBGYN Society and the various Georgia medical networks to get the information out directly to the people that it impacts in terms of the medical side of things. But then we're also going to these doing these presentations for the advocacy organizations and the groups that can maybe think a little bit more radically than Georgia's used to, and but is needed in order to address the changes that we want to see in our state. So that's kind of where we're at for future research and follow-up. Again, I hope that answers your question. We have a few more minutes. If you all have other questions or suggestions, I'm trying to see, I don't fully know who's all on our call and what you work for, but again, the one thing we weren't anticipating was COVID, and how COVID has completely rocked the emergency department world and maternal health world and just healthcare in general. So if you all, depending on the organizations or the communities you work for, have thoughts or suggestions or questions based on even just that context, we would love to hear that. We certainly heard from the providers on ways to improve care for this. There was a lot of talk of telehealth and moving that forward in connecting rural patients to OB care, but I think that's one solution. I don't think it's the solution. So again, thinking outside the box is really what's going to be needed to move healthcare forward in our state. Okay, I'm not seeing any more come in, so I think we can end a couple minutes early. And again, thank you all. Please, I hope you wrote down our emails, follow up with us. We'll be happy to talk with you all. Thank you for coming to our session. Enjoy the rest of your conference, the last day.
Thank you, everyone.